Good morning, everyone. I'm Michael McGinnis, the Leonard D. Schaefer Executive Officer of the National Academy of Medicine and Executive Director of the NAM Leadership Consortium. And on behalf of the National Academy of Medicine, it's my great pleasure to welcome all of you to this webinar on Emerging Fairer and Stronger from COVID-19 Health System Imperatives. As many of you know, because this activity has involved literally hundreds of people, over the past 2 years, the NAM Leadership Consortium, which is comprised of leaders from multiple sectors, focused on the impact of COVID-19 on 9 specific sectors with the aim of understanding the dynamics and the challenges of COVID-19 within each of those sectors. But in addition, and especially with the mandate of looking across the system as a whole to better understand the system-wide fragilities that need to be engaged if we're going to redress the problems that were confronted and move forward in an effective fashion to achieve the kind of health gains that we know are possible given the resources, the science, and the commitment of the nation. We have a wonderful session today, which is going to begin by a look back on the results of the COVID-19 sector assessments. We've got 3 wonderful presenters who represent the dozens and literally hundreds, ultimately, of people who were involved in those assessments. Suzanne Miyamoto from the American Academy of Nursing, Georges Benjamin from the American Public Health Association, and Peter Lee from Microsoft. I'll introduce them again later. And then we move to the second half of the conversation to review and present the follow-on National Commission that is being launched by the National Academy of Medicine in partnership with a number of key organizations. And you'll hear from 2 of our key partners in the course of that conversation as well. This National Commission on Investment Imperatives for a Healthy Nation, which carries the name accordingly consistent with the previous sector assessments, Emerging Fairer and Stronger from COVID-19. It was very clear in the course of the work of the sector assessments that the issue of equity and fairness is at the top of the agenda of our shortfalls in this nation. We will introduce the speakers from the second panel at the time that we move to that presentation. And what I'd like to do now is run through just a short introduction of the overview of the activities under the Emerging Stronger Sector Assessment Initiative. And so if we can move to the first slide. And here is a brief summary of the sector impact assessments, which were conducted by, again, field leaders and leaders on the NAM Leadership Consortium to assess the experience of each sector during the pandemic, the especially prominent challenges and opportunities in each sector, and cross-cutting system-wide vulnerabilities and transformation priorities. Those sectors were, just to remind, clinicians, patients, families, and communities, care systems, health payers, public health, quality, safety, and standards organizations, the research community, digital health, and health product manufacturers and innovators. Although we only have 3 of the sector authors with us, they are 3 of the best informed and most experienced and broadly based. And while they won't try to speak for each of the sectors, you can see that the activity has been very robust And we're very grateful for Suzanne and Georges and Peter Lee for joining us today to give an overview of elements of the activity. Next slide, please. The short take with respect to the defining problems that were identified as lessons learned across all the sector assessments were: number one, system fragmentation; number two, misaligned incentives; and number three, structural inequities. These were three issues that were identified as fundamental challenges in each of the sector assessments. There were a number also of cross-cutting solution sets identified. And here you see 5 listed: financing that is linked, integrated, seamless, and focused on outcomes for people and populations. Secondly, digital interoperability and shared data. Thirdly, culture and accountability focused on matters most important to people in their communities. And fourth, learning that is real world, continuous, and timely. And fifth, public health integrity as an explicit responsibility of every organization and every stakeholder in the health field. Next slide, please. Now we turn to the presentation of our 3 co-authors of the sector assessments. Dr. Suzanne Miyamoto, who is the CEO of the American Academy of Nursing; Dr. Georges Benjamin, who is the head and executive director of the American Public Health Association; and Dr. Peter Lee, corporate vice president of Microsoft Research and Incubations. Thanks to each of you for your leadership to this point. And let me now turn to Suzanne for comments.
Well, thank you, Dr. McGinnis. And I want to reinforce Dr. McGinnis' comments earlier on the tremendous level of expertise all of the authors who contributed to my particular section on clinicians, and in particular, my co-lead, Dr. James Madeira at AMA. I wanted to provide a little context of kind of where our sector analysis really saw some of those challenges, as Dr. McGinnis pointed out, and where we do see some opportunities that continue to emerge. So as we think about the sector, in particular clinicians, burnout, fatigue, moral injury, and broken trust have significantly impacted clinicians during the pandemic. And we know that the road to recovery of clinicians is individually based, and each healthcare provider is going to have to take the time, and their unique process for healing will be take that time to do so. The trauma experienced by clinicians was vast and encompassed each of the major issues of this workforce, which it seeks to address, as workshop seeks to address, and that's systematic fragmentation, perverse incentives, and structural inequities. As our sector assessment on clinicians and professional societies did point out specifically, this stress stemmed from assuming new roles, the distribution of professional networks and those disruptions to those networks, as well as the accumulation of emotional suffering that occurred because clinicians were isolated from their families, their friends, and again, those professional networks. From students to faculty to frontline clinicians, the structural barriers and inequities impacted their ability to access the resources they needed to provide the best care, or in many students' cases, to pursue their best education. Take, for example, the shortage of supplies, in particular PPE, which risk providers' own safety as well as their patients, or the continued lack of interoperability of electronic databases that delayed the transmission of data to make clinical decisions. Another factor impacting care was the financial instability around during the pandemic that caused disruptions to clinical reimbursement that weighed heavily on the provider as well as the system, with many non-emergent procedures being canceled. The moral distress and injury resulted from providers, including nurses, grappling without being able to fulfill their obligations to patients or believing they were inflicting further harm rather than healing. Within academia, the almost immediate transition to online education further highlighted the disparities for students with or without access to broadband or high-speed internet, as training was immediately switched from in-person to virtually, and a lot of that simulation and patient simulation done in that virtual setting. Additionally, the responsibilities for caring for family at home, we witnessed that responsibility fell disproportionately on women and proved to be challenging to balance both work and school. The disruption to research also paused growth for researchers and doctoral students whose labs were closed or repurposed for COVID-19 activities. These are only a few of the examples, but highlight the fragmentation and structural inequities our sector discussed. As we have emerged from the most intense years of the pandemic, it is clear that one unmistakable challenge must be addressed: how to care for those who provided care and who still provide care. A massive multi-level investment must be placed on clinician well-being and resilience, which involves supporting the individual and improving the system in which the individual provides care and the academic model for future clinicians. It cannot be underscored enough that recovery efforts must come from within the healthcare system, as well as efforts from private and public sectors, because we are by no means out of the woods. The timeline to repair health, trust, and implement sustainable and effective practices does not have an end date, nor is this unigenerational. Consider the students who were in school during the pandemic and now are working in the field. They are experiencing the dual effect of learning and caring after COVID. Within the nursing profession, the impact of the pandemic is felt as the workforce sees dips in numbers and satisfaction. In April of 2022, Doctors Peter Bierhaus, David Arbach, Karen Donnellan, and Douglas Strenger published a nursing workforce analysis in Health Affairs, which found that the total supply of RNs decreased by more than 100,000 from 2020 to 2021, the largest drop ever observed in the last 4 decades. A significant number of nurses leaving the workforce were under the age of 35, and most were employed in hospitals. In March of 2022, the American Nurses Foundation and the American Nurses Association released results of its 2019 COVID-19 impact assessment survey that found that 52% of nurses are considering leaving their positions, primarily due to insufficient staffing, work negatively affecting their health and well-being, and the inability to deliver quality care. In addition, 60% of acute care nurses report feeling burnt out, and 75% report feeling stressed, frustrated, and exhausted. Similar stressors face other healthcare professions, as we reported in the National Academy of Medicine's National Plan for Workforce and Wellbeing, which was released just last month. 54% of physicians, 60% of medical students and residents, and 61% of pharmacists feel burnt out. Metaphorically, the pandemic was a trillion-ton weight on an already stressed system that bowed infrastructure and provider resilience, so much so that it goes beyond simple repairs, but also rebuilding. Our sector identified key domains on transforming clinical practice, innovations in education, and trying to address policy with addressing health disparity. As we consider what needs to be expanded, it is the work of the National Academy of Medicine, the Action Collaborative on Well-Being, to address all of this: the digital infrastructure, the workplace barriers, removing those practice barriers. Overall, I just want to be able to stress that this is really the partnerships that needs to move forward in our 2019 COVID-19 emergence of looking to our federal partners, our state partners as well. I just want to end by saying that last night I had the opportunity to work with my Georgetown students, and I asked them what would be the future if they could envision it. And they have really discussed the ability to rebuild and rise to the occasion. And I think that is an indicator that we see hope despite all of these challenges that we face.
Thank you very much, Suzanne. You've underscored beautifully the stresses throughout our society, in particular on health providers on many dimensions, but health providers reflecting the tremendously challenging circumstances of their patients. Fragmentation in our system is again underscored, as you indicated, as a basic challenge. Whether provider or patient, if you feel isolated and you feel you're facing a system that is not working in a coordinated and effective fashion, the challenges are even greater. So thank you for raising and reviewing the issues and the good work of you and your colleagues. We'll move now to George's Benjamin. As we do, let me suggest that people who have questions for consideration and taking up in the discussion session, please put them in the chat, and we will come back to them after the three authored discussants. So, Georges.
Hi, Dr. McGinnis. Thank you very much for allowing me to spend a little time with you this afternoon. Just remind us all that, achieving and protecting our health is a very, very complex process. We in our country actually have two separate systems. We have a public health system, which is fundamentally run by government, and we have fundamentally a private healthcare delivery system, although there's a government component for regulation and certainly fulfilling holes in our system. And anytime you have two systems like that, and the systems get stressed with such an amazingly powerful event like COVID-19, it's going to show stress and it's going to show cracks. And there's no question that we saw that. We know that we spend over $4 trillion for healthcare in our system, and yet we don't get the best outcomes. But we only spend about 3% of that on the prevention and wellness public health side of the equation. And that definitely showed. Our report tried to illustrate that quite clearly. Peter's going to talk a little bit about IT later, but let me just give you an overview of the fact that we absolutely don't have the kind of health information highway that we need. I remember in 1956, I was about 3 years old, but President Eisenhower, through the Federal Highway Act, passed an act which actually built our national highway system that we benefit from today. They did it for national security reasons. And we finally need to once and for all build a health information highway so we can move data quickly, that we can de-identify information quickly. So we know that George Benjamin in System A is the same George Benjamin reported in Data System B. We have to make fax machines either a museum relic or something that's done as a third backup system when everything else fails. But we were using fax machines and pen and ink to move information around, sometimes information that was days old, which showed that our system really hasn't modernized to the extent that you can get food, you can get a hotel reservation, you can get an airline reservation, you can move information almost every other part of our society around very quickly. And this is something that hopefully the commission we're going to talk about later is certainly going to ultimately address. We need to do data modernization and surveillance disease modernization at a variety of levels. We know that the workforce, we have an aging workforce. Not only did we just hear from Suzanne about the stresses on that workforce and the fact that that workforce is leaving in droves throughout the disciplines, but it's also true in public health. Public health has been saying they're going to retire. Well, they're finally going to retire. And it's a workforce that has been understaffed for many years. And in fact, by the way, we don't even know for sure how do we define the public health workforce. We still have big debates about whether or not people in clinical care, depending on where they work, are part of the public health workforce. What do we mean by public health? What is the standard operating classification that we need to put together so that when someone says, I want to measure the public health workforce, we can actually know what it is and know who we're talking about, and how we track that enumeration over time is going to be very important. We also need to think about how we train that workforce for the future. We have a lot of things that are going to happen to us over the next several years. We have an aging population, and we're not necessarily, not even on the clinical side, but on the population health side, prepared to deal with that aging population, particularly that population that wants to age in place at home. And it creates a whole range of issues. We saw that with the recent hurricanes in Florida, in terms of knowing where people were, trying to evacuate them, trying to provide for their needs. And that continues to be a big issue, and public health will do that and does that on a daily basis. We know that our governance structures need a lot of work. The accountability for governmental public health needs a lot of work. We still have way too many small health departments that don't have the full capacity to provide the services that every community deserves to have. And we have a lot of work on political support. As you know, we had, because of misinformation and disinformation, threats to a whole range of healthcare workers. It caused part of the dysfunction and concerns that workers had in the clinical side. We had just as much, if not more, on the public health side. And we had the political overlay around issues around vaccine hesitancy, around masking, around social distancing, and in many cases, the lack of ongoing political support for those professionals as they did their work. I think it's going to be important, finally, that we pay a lot of attention to culture. And one of the things that public health has been very good at is being invisible. Now we're operating public health in a fishbowl, and we're very visible. But we also, in public health, tend to do things at the speed of academic discovery, which is often very slow and deliberate and thoughtful, at a time when we really need to have fast science, fast communication, and accurate communication, and really function in a way that is more like emergency physicians and emergency nurses and emergency departments than outpatient programs where you have time to think about problems, to solve those problems over time. We have to change the culture of public health practice so that it's very timely, very fast, when we need a very timely, fast response. Our report talks about all of those kinds of systems changes as part of our learning system. And then finally, I would be remiss if I didn't point out the fact that we had all these discussions after 9/11 and the anthrax letters. And many of the lessons that we thought we had learned and things that we thought we had put in place 20 some years ago fell apart. And so if we really want to have a learning system, then we need to have a system that not only learns, but retains those lessons, integrates those lessons into the systems that we have, and then works to move them forward. Mike, with that, I'll stop and let Peter go on with his presentation.
Thank you very much, Georges, and thanks for your sustained and very visible, fundamentally important leadership to the public health community. In your remarks, among the many important observations was the fundamental importance of aligning the public health community as a key and fundamental responsibility of every sector and every stakeholder, and to ensure that, again, the stresses that we feel when the alignment doesn't occur, when we are working in relative isolation, the results are quite dysfunctional. And there's just no question that your clarion call for commitment to public health is one that can't just be taken up by the public health community, but it has to be arms locked around all sectors for the gains to occur. You also mentioned the digital highway, if you will, the information highway. And that is the nerve system that allows our health system, could allow our health system to function effectively, efficiently, equitably, and continuously learning. And while we have the technology capacity rapidly developing to do that, we're again in a fairly fragmented scene. And we're now going to hear from Peter Lee, who's corporate vice president at Microsoft for research and incubations, and who, along with Amy Abernathy, who's also you'll hear from later on, headed the work on our digital health sector assessment. Peter, thank you for being with us.
Thank you, Michael. And indeed, it was really a privilege, a joy, actually, to work with Amy Abernathy, David Shaywitz, and all the other contributors and co-authors on this sectoral assessment on digital health and the lessons learned during the pandemic. I think I'd like to start just by acknowledging that it's pretty common. In fact, sometimes it feels almost fashionable to complain about what feels like a really slow stop and start kind of progress on bringing healthcare and medicine fully into the digital age. My own view is that it's a little bit like watching grass grow. Actually, over the last 2 decades, so much has been accomplished. We have now almost all medical records fully digital. Radiological images are digital, and more commonplace now, digital pathology. We have fully digital transmission and reimbursement for prescriptions, claims, lab test orders, results. Within clinic at hospital bedside, all monitoring equipment today is digital. The equipment is digitally tagged and tracked. Surgical equipment, the same. And increasingly, the data produced by all of this digitization is being used to train through machine learning new AI-powered enhancements to detect disease, to lead to better and faster diagnoses, to reduce medical errors and reduce costs. That digitization has also made it possible for consumers to take more control over their own health and wellness. Smartwatches are commonplace now, internet-connected home exercise machines, online mental health services, and mental health maintenance applications. Increasingly, appointment scheduling for appointments with health professionals, telemedicine, and so on are increasingly widespread. And in fact, anyone who works today towards addressing healthcare's major aspirations, addressing inequities, understanding the impact of social determinants, reducing costs, achieving the triple aim, anyone working towards those aspirations sees digital health technologies as an essential component for any practical progress. And all of that was progress that was really defining our current state of affairs when the pandemic hit. Now, when the pandemic did hit, it, of course, then was logical that the US healthcare community looked to the system of devices and digital platforms and digital data to address critically important questions. And some of the most basic questions were things like, who are the most vulnerable people and where are they? Where is the infection spreading next? What capacity does each health system have for treating those patients? And what is the utilization of that capacity? For each health organization, is there an adequate supply of things like PPE? And if not, where can it be sourced? And then more fundamentally, there was also a hunger for data to inform our biological and medical knowledge of a novel disease. We needed data to understand the importance of comorbidities. We needed data to gain key insights into treatments, things like the proper use of steroids. And we also wanted to capture and disseminate best practices for keeping nurses and doctors safe in the treatment of COVID patients. And so while telemedicine was a notable success of digital health during the pandemic, for those types of questions in the early months of the pandemic, we were essentially flying blind. Our electronic health record systems had records on thousands of COVID patients, but those records were often hard to find because we lacked coding for a novel disease. Digital systems for electronic health records were not connected enough to enterprise resource planning systems. And neither of those were connected, as Georges was saying, to the public health system. And thus it was almost impossible to coordinate patients with PPE and other capacity, nor inform public health professionals where to dedicate their resources. Clinicians ultimately took to Twitter to share their observations, such as the importance of keeping patients prone with other researchers. And paradoxically, the digital divide only served to magnify the existing inequities in healthcare. Fundamentally, for a techie like me, it was just incredibly frustrating. The power of artificial intelligence and machine learning that we're so proud of just felt so frustratingly out of reach time and again, especially in that first year. And as a techie, I and countless of others of my colleagues just leapt into action. And we created hundreds, maybe thousands of new digital systems to try to improve the situation. But more often than not, our urgently deployed systems only added to the complexity of an already overly complicated digital health system. Maybe the biggest disappointment was when, in the middle of 2020, or early 2021, Vice President Pence found it necessary to ask every health organization in the US to fill out on a daily basis an ordinary spreadsheet and email it in to the White House each day in order to capture data on capacity and utilization. That's just a solution that would be considered archaic and completely unacceptable in almost any other industry in the United States today. Now, the picture I've just painted here is bleak, and some reviewers of our sectoral assessment actually complained vigorously that we were way too negative in our assessment. And perhaps they were right. As I said in the beginning, in reality, a tremendous amount has actually been accomplished over the last 2 decades. And in time, our digital response to COVID-19 did do wonders and helped save many lives. But the fact remains that we expected better. We expected much better. In our writing, we referred to the poem, The Rime of the Ancient Mariner by Samuel Taylor Coleridge, which has the famous line, "Water, water everywhere, nor any drop to drink." Despite almost complete digitization of individual components of healthcare, far more effort and far more time was needed to quench our thirst for high quality, actionable data. The core finding, therefore, of our assessment was that while we have successfully digitized nearly every individual component of the healthcare system, what we lack is a platform that enables it all to work together. Such a platform would consist of a data architecture that enables modular design and a core infrastructure to support it. The way to understand this is to use an analogy that we presented to home building. Imagine if we wanted to build a house. To do so, we would need lumber, concrete, and pipes. You can think of this as the data. We would also need hammers, saws, measuring tapes, and other tools. You can think of this as the tools of data analytics, machine learning, and so on. But most importantly, we would need architectural principles for home building with modular components that allow for independent, coordinated innovation. For a house, we have this. We have foundation systems, distinct from framing, distinct from roofing, plumbing, HVAC, electrical, and so on. Each has a defined set of principles, building codes that ensures that we can hire a roofer, a plumber, a carpenter, and they can do their work without getting into each other's way. As a general contractor, I can make a legal contract with each subcontractor and they can all go about their work. Without this modular architecture, imagine what it would be like to build a house. If we have N different people working on the house, we may need bilateral legal contracts amongst all n factorial pairs of builders to establish who does what and with what designs and materials. That would be wildly impractical and onerous administratively. But in fact, that is the situation that we have today in digital health. The bigger issue is not that administrative burden and that complexity, but the impact on innovation. In today's home building, if a startup company has a better idea for better windows, it can innovate and sell those windows to a single large market with the confidence that their better windows will integrate into any house in a standard way. By analogy, any innovator in digital health today has to do artisanal vertical integration into each hospital's and each clinic's completely unique digital setup. As the old saying goes, if you've seen one hospital's digital system, you've seen one. And so our fundamental charge to the nation is to work towards defining a standard architecture and based on modular architectural concepts that will help tie the impressive progress we've made in digital health together and spur innovation. Thank you.
Thank you, Peter. Again, not only for your fine presentation and review of the key issues, but for your leadership, along with your co-authors in developing an extraordinary paper. And on that count, I think you've had, all of us in the audience here, have had a little glimpse of the depth and quality of the papers that were produced, the 9 papers and cross-cutting paper in the Emerging Stronger publication that are serving as the basis for our moving forward. And I would encourage you to access those papers when you can, and you'll be enriched and informed for constructive action moving forward. Each of our speakers has referred to some of the important conditions that need to be ready in order to move to a better integrated system. That's a term that Peter referred to, and talking about the integration of our data capacities, and integration and alignment is obviously of fundamental importance moving forward. And we're going to talk a lot more about that in the second half of our conversation. But another important dimension is ensuring that the financial incentives are lined up well, and we'll get to that a bit more as well. But one of our questions that we have here is, what more can be done to bring the payers to the table in this struggle? And George, let me turn to you to give a little advance on this. It says that there are no incentives for them to work alongside providers in public health on this, but it seems that payers are best positioned from a resource standpoint. When, how, who among them can be held accountable?
Yeah, we actually do have a lever in that area. It's called the community benefit assessment that they do, at least for nonprofit hospitals. They have a requirement to both assess the health and well-being of their communities, and then to try to address that as part of their obligation as a nonprofit. And so basically the IRS could work collaboratively with CMS and other parts of government and do this in a collaborative way to try to strengthen the hospital's engagement using that community benefit assessment as one way to do that. The second thing, of course, is through the various preparedness grants that go out to hospitals to require that they work collaboratively with the health departments. And then on the dollars that the health departments get through Center for Disease Control and Prevention, through ASPR, and through HRSA, basically HHS grants, to do exactly the same thing, to make sure that the health departments are meeting on a collaborative basis with their various hospitals in their community. They do so. It's usually something that happens, but it just isn't happening as often enough or with as much efficiency as it needs to be. So we have financial ways to do it. I think finally the thing we need to do is there's an effort right now through CMS to look at ways to pay and cover the cost for addressing the social determinants of health. Health departments can be enormously helpful in that transition. And so there is probably a financial mechanism through CMS to both enhance the work from a policy perspective of state and local health departments, as well as to strengthen the partnership between hospitals, the healthcare delivery system. And by the way, remember, most of the healthcare gets delivered also outside the hospital. So engaging physicians and other practitioners in their offices as well as hospitals will be another part of the system that we have to work on.
Thank you very much, Georges. Let's turn for a bridging question in some ways to Suzanne, one that refers to both telehealth and to financing. And you raised both issues in your comments. And the question is, how can telehealth be better leveraged and can incentives to do so be better aligned with in the insurance industry broadly?
Well, I just wanted to echo George's comment. I think, the partnerships when it comes to payment is incredibly important. And I'm sure many of you have seen CMS's new framework from 2022 to 2020 or 2032 that really addresses health equity and using some of those innovations. I think our sector also identified when it came to telehealth some really important innovations where we saw care happening in the community and then being switched to telehealth. And one example, that came out of this model is the caring science model of specialized dementia care for transforming practice and advancing health equity. And this really looked at flipping the model of being in person, taking care of patients and family with dementia care to that virtual and telehealth experience. And I think that reimbursement is incredibly important for providers who are designing those models and using that import. I think, again, I just reflect back on the partnerships because while we see CMS and other entities moving in the direction of better payment structures, looking at health equity, looking at telehealth, we need to be championing the examples like this dementia model that really do improve those transformations. I think overall, what I would, kind of just conclude is we also be needing to think about the barriers that need to be removed. The COVID-19 pandemic released some of those practice barriers that we saw to expand who could provide care and increase that access, and ensuring after that we can continue to keep those barriers removed so providers are able to practice to the full extension of their education and training and be able to provide those services in their communities, as George has mentioned, not necessarily always in the healthcare system.
Thank you, Suzanne. And let's continue the conversation by moving to Peter. And again, I'm going to blend two of the questions that I have in front of me here, and I think we all have in front of us. One of them draws on your example, Peter, of home building as another sector to learn from regarding health data systems integration, and notes that in addition, there's another transactional system in play, the ATM system, in which we get cash from accounts with another bank. And the thought experiment that's positioned here is, imagine if we could walk or be brought in unconscious into a health care provider anywhere and have our data accessed in a much simpler fashion from anywhere that it resided. And then there's a related a question in the chat that refers to the notion of what exactly is in the pipeline now, as far as you've seen, as far as your work with the public sector goes, to get rid of too many computer systems and medical records, data, and work on a national unified digitalization system. In effect, the ultimate integration that you were referring to, communicating all portions of the U.S. community. Thoughts on issues and developments? And before you answer, since we're running out of time, I'm going to indicate that we will have one more quick run through with each of our panelists, asking them to give their, if they have to make one recommendation to the commission on a priority that they feel is most important to engage, what would that be? But first, Peter, over to you.
Yeah, I'll try to be very brief. I think the financial services sector is very interesting to look at. And as we've discussed actually in the paper, we suggest an exercise where we look at different sectors where the modular architectural kind of component design has been very well defined. Home building is one, but there are more significant ones. The financial services sector is one, telecommunications sector is another. There are large sectors of manufacturing, supply chain. And if you imagine, what the block diagram is for those, for the architectures that allows, for example, global telecommunications to work as it does today, it's quite complex, but those blocks are defined. And in fact, much of the regulatory constraints on what those blocks can do is owned by the industry, therefore putting regulators really in a very well-defined role. And that allows innovation to take place because an innovator focused on one of those block diagrams, one of the blocks in the block diagram, has some confidence that they might be able to address the entire, let's say, global telecommunications or financial services market. So it's a very good point. On the specific thing about the ATM example, one of the wonderful things that the financial services architecture has done is it has clearly identified what parts of the system accept financial risk. So when you use your ATM card or you use your Visa credit card, there is a very direct assignment of risk, and that drives the need for data in order to do the machine learning, in order to calculate ahead of time whether that risk is warranted. And I think it's definitely true. It would be wonderful to have the same situation when we're talking about claims and reimbursements. It is somewhat of a flipped situation, so it's not clear how that should go. But again, that would be an example of the type of question that could be addressed once we think architecturally.
Thank you, Peter. Let's do our lightning round and your highest priority from your personal perspective for the commission that is fundamentally focused on integration and alignment to engage. Georges?
I think working on fiscal sustainability for the public health system. Public health works in a boom and bust environment. It doesn't work. The incentives aren't aligned for anyone to do anything over a long period of time.
Thank you, Georges. Suzanne?
I think I reiterate the clinician well-being, because clinician well-being impacts how we reform the system, the digital infrastructure. All of those pieces will weigh in back to how they can provide care. And I think overall, we know that providers are there because they want that human connection. They want to provide that best care, but we must figure out how to reform the system from payment to otherwise to be able to ensure their well-being as part of that.
Thank you, Suzanne. And Peter?
Let's not fixate entirely on standards and data standards. Again, making the analogy to home building, it's great that we have standardized 1-inch pipes or standardized threads and standardized 2x4s and 4x8 plywood sheets. Those standards are important, but you need also that component block diagram, that architecture.
Thank you, Peter. And again, thanks to all of you, and a virtual round of applause from all of us for your contributions and your ongoing leadership. We're not going to hand the baton because these folks are going to maintain a firm grasp on the baton as well. But symbolically, we're going to hand the baton over to our discussion of the National Commission and follow-on activities. And I will give you just a brief set of introductory framework comments on the structure and work streams of the commission and the background on them. And then we'll turn to our two partners on the communication front, Eric Rubin from the New England Journal of Medicine. And obviously, I can mention right now that Eric is with us for much more than just communication, but the New England Journal has graciously volunteered to use their incredible communication capacity and know-how to help us develop a strategy, not to use the New England Journal for every activity, but to develop a strategy as we move along. And also we'll hear from Dwayne Proctor, the Missouri Foundation for Health, again, who has stepped up to help us form a local foundation and funder coalition so that we can anticipate getting input from the front line and triggering action on the front line. And then we'll have a panel of reactors. We'll talk about the commission itself. Meena Seshmani, who is the head of Medicare and has been actively involved as a leader in this arena for her entire career. And several of the questions that came up earlier are relevant to Medicare, so she'll reflect on what might be helpful in that respect. Amy Abernathy, who you've already heard, was actively involved in the digital health paper and is now leading clinical assessment work at Verily. And David Erickson, who's from the Federal Reserve Bank of New York, as we discuss capital investment opportunities. And each of those will be clear as we run through the quick introductory elements around the commission. So next slide, please. The commission aims are derived, not surprisingly, from the solution sets that were identified in the course of the Emerging Stronger sector assessments. And essentially, they're focused around strategies and priorities to eliminate increasing and often deadly health system shortfalls caused by deepening fragmentation, perverse incentives, and structural inequities, the three common denominators in the problem sets. The solutions that were identified have been translated into work streams that we'll get to in a second. But clearly, the aim of the commission as a whole is to increase alignment, and to the extent that is reasonable, integration, aligning our values and principles in health and society, aligning the incentives to achieve the aims that are most important, aligning policies so that they reinforce each other and actions throughout sectors, and aligning actions, ultimately reversing the declining health and well-being that we've tragically observed in the last several years. Next slide, please. The approach to the commission is going to be a 2 to 3 year time frame with the option of a staged follow-on, but the initial period will be as indicated. The commission will be comprised of senior stakeholders with experience from multiple sectors, recognized as thoughtful, knowledgeable, independent, without current health system responsibilities. I underscore that because obviously this is a commission that needs to be independent in its perspectives while getting as much of the rich information that exists within the operational organizations within our health system. There will be 5 working groups established, 1 for each of the 5 work streams, and populated with those with special expertise, leadership, and active involvement in the areas. Next slide, please. The work streams are the person and community motivated work stream, establishing personal and community health goals and priorities as a core design features. Equity and fairness, developing and fostering strategies for conversations, a national conversation, if you will, understandings and actions that bridge groups and cultures. Health financing, focusing payments and accountability on improving individual and community health outcomes. Data and digital health, as we heard throughout the last set of comments, accelerating digitally enabled health data security, validation, sharing, analysis, and action to drive health improvement and continuous learning. And capital flow, investment strategies oriented to advancing the nation's health and economic well-being. Next slide, please. The products will be first framing questions. Obviously, these are broad and complex issues. It's very important that we get your input and the input of your colleagues throughout the field on the right questions to ask in each of these work streams. There will be 2 products from each work stream, and I won't go through that now, but one of them will be analytic in nature, and the second will be policy in nature. And the report will focus again on the alignment, priorities, and strategies and requirements for the progress needed. Next slide, please. I've mentioned that we have two partners and you'll hear from them in just a second, the New England Journal of Medicine and the Community Philanthropy Coalition. Next slide, please. And let's turn first to our commission partner with community-based and oriented philanthropies. Dwayne Proctor is the president of the Missouri Foundation for Health. And Dwayne, let me turn it to you.
Thank you, Mike, and thanks everyone for attending this very important call. Very happy to share the news that community foundations can make a big difference in the work that's going forward. The next slide describes some of the ways, some of the many opportunities for engagement with us local, state, and regional philanthropies. And trust me, this slide is just it's just a description of where we could go and how we could work. These foundations and others, we work with our communities directly and with stakeholders to solve problems in our own jurisdictions. Many strategic philanthropies already have a stake in this work and acted swiftly to deploy resources at the outset of the pandemic. In fact, according to the Council on Foundations, our umbrella association group, and as of June 2022, more than 500 community foundations across all 50 states mobilized at least $500 million. And then many other foundations made commitments to go even further. And so those numbers, that dollar amount will change. All that to say is that we are available. We will work together and do things that we haven't done. We will serve as channels for communications from our communities so that community voice can be heard and is apparent as a part of this work. We will act as trusted partners on implementation, as brokers, so to speak, so that relationships at the local level can be supportive of this initiative at a national level. And we will learn much from emerging fairer and stronger because this project will provide us opportunities for working together across our jurisdictions, will provide us opportunities to advance health equity as part of a national initiative, and will provide us the opportunity so that we will all be better prepared for future crises like this. And that's the end of my comments on this. I look forward to the work to come. Keep in mind that this slide is merely descriptive. These foundations have not been contacted yet. And there are many others that will be contacted in addition to those that are here. Thank you very much.
Thank you, Dwayne, for your leadership and for underscoring the fact that we're still very much in a listening and encouraging suggestion phase. And on that count as well, I'm pleased to introduce with much appreciation Eric Rubin, who's the editor-in-chief of one of the world's leading medical journals, as some would say the leading medical journal, the New England Journal of Medicine. Eric, thank you for joining us as a partner and for bringing your expertise on many dimensions to the fore, including the superb communication and outreach dimension.
Thank you, Michael, and thank you for endorsing us as the leading journal. That's nice to hear. We had sort of the ultimate front row seat to the outbreak because our editors are physicians and took care of patients. Many of them helped set healthcare policy. We also got to see, though, the tens of thousands of manuscripts that came in describing research and clinical care and patient and clinician experiences during the outbreak. It was really gratifying to see this outpouring of information. On the other hand, the volume was overwhelming. And if we who do this as professionally felt overwhelmed, you can only imagine how caregivers and patients felt trying to digest that incredible volume of information. So going back to what George had said earlier, we really need to provide the tools, the communication tools to our researchers, to our public health professionals, to individual clinicians to help people sort out what's real and what's not real, what's important and what's not important, and let them evaluate those data themselves in a way that gets them to a real understanding of what's going on. Of course, as you said, Michael, we have a simpler goal for our role in the commission, and that's in part to help communicate the findings of the commission. And I hope we can work together to do that. This slide lists a lot of our own publications. We in no way intend for that to be the only outlet for the responses that we see from the commission members. But we'd certainly like to leverage the position we have in medical communications to help enhance that. And we really look forward to working with you and the commission members and all the other participants.
Thank you, Eric, again, for your partnership and insight and for being with us today. Let's now turn to some reflections from experts who have been involved in leadership positions at the most visible and senior levels for a number of years, and who are in a particularly well-placed position to identify the key elements of attention for the commission as it gets underway. And I'm pleased to introduce as our first presenter, Dr. Meena Seshmani, who is the director of the Medicare program in the Department of Health and Human Services and a longtime leader in health policy. Meena, thank you very much for being with us.
Thank you so much for having me. This is really exciting work that is underway. Shall I just kick us off then?
Please.
So, you know, I think what is most exciting about this, both from my perspective, having recently led in a health system leading, you know, the COVID response for the DC, Maryland area, and now leading the Medicare program, is the emphasis on the alignment of multi-sector efforts. You know, where the work has demonstrated the systemic fragmentation, the misaligned incentives, the structural inequities, all of that comes to how do we expand our aperture of how we view healthcare to really take into consideration all of the factors that impact someone's health. And I think for all of us involved in learning from the pandemic and improving the health system moving forward, it's about now connecting those dots where different parts of the system have different levers that can be utilized. And how do we make sure that they are all being used together where the whole is greater than the sum of the parts. So I think that is one of the key things of the work of this commission that will be really critical. And again, this is where coming from someone who, you know, leads Medicare, which is, as you know, the nation's largest payer, at almost $1 trillion in claims, 1 in 5 healthcare dollars. There are certainly large levers that we have in the Medicare program that do have ripple effects across the entire system. And yet, Medicare alone cannot do this work. So as an example, we are really trying to drive more holistic care models. As you may know, these accountable care organizations where providers come together to take care of their patients with measurement of quality and ultimately spending money in a smarter way. Providing better care leads to better outcomes, keeping people out of the hospital, out of the emergency room. We are launching a program, advanced investment payments, to be able to give money up front to healthcare providers in rural and underserved areas that they can use to invest in their infrastructure, in team-based approaches to care, in addressing social needs of the people that they serve. So we're going to be rolling out this program. We finalized it in our recent regulation. And that program is only going to be successful if we have concerted efforts across the communities, across the ecosystem, coming back to something Dr. Proctor mentioned in his remarks, where we can leverage community-based organizations and others who are involved in care to partner with these providers where we have a lever to support the providers. Well, how do we make sure that we are raising the entire community. So on our end, we're partnering with the Health Resources and Services Administration. Are there workforce grants that can help support, in this team-based approach with the CDC on the public health side? And so I think this goes to emphasize that all of us do need to be working together. And I think this commission can really help to explain that, provide a roadmap, provide examples of how that can be put into action to address the fragmentation in our system, to be able to have this more holistic approach to care. And I think that's where having that, multidisciplinary aspect will be very important. I want to comment also on something that George's Benjamin had said with public health about the boom and bust in terms of having more of that stability for the public health system. I think that's also something that doing this alignment across sectors can then really support, where if we all are in agreement that all aspects of this ecosystem are important for us to achieve the goal of healthier populations, then how do we make sure that that actually plays out in practice? And that will be something also that will be very helpful, I think, for this commission to take on, where you do have different financing mechanisms across different aspects of the ecosystem, where you have currently sometimes different metrics of what is success across the different aspects. How do we bring that into more alignment so that you have that ability to really have all aspects, moving together in a way that makes sense to drive change? So I think, I can stop there. I look forward to further discussion with my colleagues as well.
Thank you very much, Mina. And as you've heard already, there are a number of questions addressing opportunities for Medicare and CMS's leadership. And so we'll return to that if we have time in the discussion session. So let's now move to someone who has been referred to already as a great partner in the digital health work, Amy Abernathy, who also served as Deputy Commissioner of the Food and Drug Administration and provided important leadership there for the movement of the nation into a continuous learning mode, something that she's extending in her work as president of clinical research at Verily. Amy?
Thank you, Michael. And it's an honor to be here with so many friends and colleagues today. And you've already heard some about the work that we did together in digital health with Peter earlier. And I wanted to extend on some of those comments and also think about it from the point of view of FDA. As Peter mentioned, we really thought that in reviewing digital health in the context of the pandemic, we were going to be having a telehealth discussion. And indeed, telehealth was important, but really what we saw was this criticality of addressing the challenges of data, the data everywhere, and me without a drop to drink phenomenon that despite the petabytes of digital data that were being generated, we really didn't have a core data infrastructure to make use of it. And this showed up at FDA and it showed up across the healthcare system. We identified a number of critical elements in the paper that we wrote around digital health that the Commission certainly can and should think about, including access. Peter mentioned the data locked in silos, and certainly the criticality of being available to public health decision makers, issues around connectivity, and issues around interoperability. And this was largely a challenge in the US around fragmentation and infrastructure. We looked to the UK and the recovery trial or the Israel use of post-marketing data to inform vaccine decisions. And what we could see were remarkable activities happening around the world that can serve as a roadmap for where we can go in the future. And also, despite the challenges that we ran into the United States, we learned over time that we could indeed do clinical research better. We could accelerate bringing life-saving treatments to people who need them by learning and leveraging adaptive pathways, emergency use authorization, and then continuous evaluation across the life cycle of medical products like the COVID-19 mRNA vaccines. And really, I think this story played out in front of our eyes in the context of the pandemic, a story that I think that the commission really should focus on, and that's that the landscape of medical product development, drug approvals, vaccines, diagnostics is really shifting so that we are able to get those treatments that are being developed. These are quite miraculous and momentous treatments that we saw developed in the context of the pandemic into the hands of doctors and patients who need them earlier and based on a smaller corpus of data. But if we're going to do that, we're going to need to build and have the systems ready for continuous evidence generation across the life cycle of the product beyond just the initial period of evaluation. And so that was another kind of critical thing that we saw in the context of the pandemic. Thinking then about what the commission may focus on and some potential commission priorities. Certainly you would guess that I'm very focused on having the full assessment of the qualitative and quantitative stakes and perspectives that could inform how we build our evidence generation infrastructure and how we build the infrastructure that allows us to leverage all available data. We should be reviewing international examples, including, for example, what has happened in Israel and the UK. We should be getting input from regulatory and policy stakeholders, including about the risk of future pandemics and how do we be most prepared. And we should also be prepared for the novel treatments that may become available in the context of such subsequent pandemic. So one of the things we saw in the context of COVID-19 was that the mRNA technologies were on the precipice of being ready and we could leverage them quickly. How do we have that same kind of preparation? Can we move fast as we best understand what is ready to become and be made available in the context of a new public health emergency? So opportunities that may inform your recommendations and strategies. Well, certainly the common theme is going to be investment in health data infrastructure. From a policy and regulatory perspective, I really encourage us as we think about investment in national digital infrastructure and data architecture to look towards public and private task forces to help us assess and enable this. The modularity described by Peter, the building blocks, is critical. And this needs to be component architecture with thoughtful standards. It doesn't mean we need standards for everything, and we should not be standard nihilists, but rather thoughtful standards that support innovation as described by Peter. We need to resource and empower FDA, certainly helping the agency have on staff the core expertise needed for complex decision making. This means we need the pilot programs and the expertise now so that we can nurture it in preparing for another pandemic. We also should see FDA as kind of a starting point or preparatory step and helps us understand and empower our other agencies. Our government agencies are our building block to how we care for our population in the context of public health emergency, and we need to make sure that they are fully prepared, and this includes CDC, CMS, and across HHS. I encourage us to keep stock of our adaptive regulatory pathways and learn how we used the emergency use authorizations in the context of the pandemic, and how do we expand that thinking going forward, including within the context of evolving evidence generation. And certainly we learned so much in the context of the pandemic around promoting diverse and patient-centric clinical research. Let's not lose that. On a health system perspective, ongoing training to make optimal use of our digital health infrastructure. The best way to be prepared for the future is to use the infrastructure we're building now so we know how to put it to work. We need to build partnerships with our digital health providers across the ecosystem. And man, oh man, we got to get cybersecurity right. I saw from the inside the issues of risk from a cybersecurity perspective in the context of the pandemic, and this is not for the faint-hearted. From a technology perspective, we need to build systems that generate longitudinal data. We need to promote interoperability, and we need to promote access to data while preserving privacy. Lastly, how do we do this well? One thing that I think is really important is we need to have in our soul that this is not just an IT activity, but rather something that has to happen across all of the different actors in our system. Technical experts need to be part of the conversation, but we can't regulate the conversation just to one group and think it's going to now look the way it needs to look for our next public health emergency. It actually needs to be all across our system working together, including regulators. We learned in the evidence accelerator that was motivated by the FDA and run by the Reagan-Udall Foundation that we could bring agencies, health system, data providers together and have them constantly learn from each other in a fast action approach. We need to leverage those kinds of experiences now and have them prepared for how we do this in the future. We need to learn from shared goals and parallel work streams. And importantly, I would like to ask, as my final clarion call, how do we extend the learnings post-COVID to actually have a very meta learning? And that's really that this is our opportunity to make it clear what a learning health system looks like and learn from the details of what we started to put in place here in the context of the pandemic of how we learn how to learn and how we make that part of just how our health system works in the future. So thank you very much for asking me to be a part of this conversation, Michael.
No, thank you, Amy. And thanks for your sound counsel and insights. And we're now going to move to David Erickson. Before we do that, I'd just like to give again a heads up to each of our three panelists that we will have before we close the session, a quick lightning round for you to offer your personal insights about the most important issue from your perspective for the commission, let me put it this way, the most important result of the commission's activities. And now let's move to David. And David, thank you for joining us. We understand that you have many alligators snapping around in the economic environment in which you work. And it's very important for us as we think about the opportunities for the nation's future health and well-being, economically and in the human form, to harness engagement with the capital investment community. And we'd really appreciate your thoughts and guidance on that count as we move into that work stream.
Thank you, Dr. McGinnis. And yeah, there are a lot of alligators at the moment. And, you know, we get a lot of headlines here at the Federal Reserve for sort of fighting inflation. And, you know, arguably we did not do as good a job on that as we should have, but we're trying to make up for it, as are many of our counterparts around the world. But the bigger role, even though fighting inflation is really central to the Fed's mission, the Fed also has the responsibility for making sure we do that inflation fighting at the highest possible employment level. That's our dual mandate: fight inflation at the highest possible employment. And ultimately, even sort of maybe even a more meta goal is to create an economy that works for all segments of society. And so that is a really important aspect that brings in health to the equation, because you cannot have wealth without health and vice versa. And this is something that the Surgeon General and our President, John Williams, have had multiple conversations about that over the years. And I have to say, like, in these conversations, I always sort of feel like I'm kind of the bad guy, because I'm always talking about, you know, markets and how you can make money at this work and things. And I do want to just, for the record, you know, I have a PhD in economic history from Berkeley. I read Das Kapital in German. Like, I'm not like a casual Marxist. Like, I'm the real deal. I mean, I believe that Karl Marx had a lot of things right. His timeline was a little off, and we live in the world that we live in. And that is one where the most powerful tool available to us is the market. And so when I hear George Benjamin talking about thinking about incentives, creating a learning system, and a learning system that retains those lessons, that to me is a market, right? That is a way in which we can make sure that we can create value, that we can pay for that value, and that in essence is buyers and sellers. And so I just want to, you know, from where I sit, and oddly, I think you can kind of see this through my window, but that is David Rockefeller built that building in 1961 to house the Chase Manhattan Bank as their headquarters. I can see the Wall Street, almost see the stock exchange, but I can see Wall Street from this office. And so one thing that I hope is that we can be a partner to the commission in this effort around capital investments that can improve the upstream social determinants of health. And the way we sort of see that is that there are producers of health. We know that arriving at kindergarten ready to learn is the best predictor of future health, that reading at grade level is a better predictor of future health than body mass index. We know that graduating from high school, having the skills you need to thrive in adulthood, those are the predictors of future health. And so we know that if we invest in the places that are lagging in all of those sort of outputs, that we can really improve the health of the nation by making strategic health investments in neighborhoods and in families and in individuals. So I think there is a real role to play in sort of identifying and organizing this marketplace. We think there are, as I say, those producers of health, whether it's building affordable housing that's safe and affordable, whether it's transportation that's bringing people to good jobs that pay a living wage, whether it's making sure that all kids are born with bright eyes and keep them bright for a lifetime, that they get excited about their future, that they're engaged in sports and drama and nature and all the things that keep them engaged. Those are the things we know, those things that they motivate people and they keep them focused on their future health. And we know how to pay for those things. And we know they create value. And if you create value, you can pay for it. So who are we talked that briefly about the producers of health, who are the, and medical care is also a producer of health. I don't mean to give that short shrift, but thanks to your research, Dr. McGinnis, we know that a lot of what really takes place, what really improves health, happens outside of the walls of the doctor's office. And so, okay, who are the buyers? So here at the Federal Reserve Bank of New York, 3 weeks ago, we had Kaiser Permanente and United Healthcare here talking about how they were investing through nonprofit banks, community development financial institutions, to build affordable housing, to improve neighborhoods. They were intending to make money on those investments, but they also were intending to improve the health of their policyholders. And this isn't just a small token investment. Kaiser's invested $400 million into this effort, and United Healthcare wasn't totally, didn't give us a total number, but my estimation is at least $100 million in that type of investment, investing in neighborhoods to improve the health of their policyholders. So we think there are buyers like Kaiser and United Health. We know there are producers out there that can make it happen. The trick then is to find the connectors who can make the sinews of that marketplace come together, come to life. And those include banks like JP Morgan Chase, nonprofit banks like community development financial institutions, foundations, government at all levels. We have a lot of buyers, or connectors rather, who can help the buyers connect to the producers of health. So we think there's a great opportunity here to just really bring in significant resources to invest in those social determinants of health and make sure that people arrive into adulthood much healthier and much better suited to weather the shocks like a COVID-19 outbreak in the years to come.
Thank you very much, David, and thanks for underscoring the element that others have mentioned along the way, and that is that this has to be very much a public-private partnership, that the private sector has to play a very leading role in our progress moving forward, as it has in many ways in the past, but calling the question at this point is an important part of the mandate of the commission, and engaging the capital investment community squarely as a partner in the analytic dimensions of characterizing how important it is for our national investment strategy, if you will, to focus on both health and economic well-being. So again, we look forward to follow up on those counts. In the Q&A, we have one that I'll read off right now. Multiple amendments to the PrEP Act issued during the pandemic enabled pharmacists to administer vaccines and dispense antivirals in ways that have not been done before. The question is, how can we keep these flexibilities so that health professionals can continue to improve access to vaccines and therapeutics? Let me change that a little bit and ask what any of the panelists, what you feel are the ways in which the commission can and ought to be cognizant of the way of the incentives that will improve the conditions of our and the effectiveness and efficiency of our clinical care workforce. And I'll, if I may, turn first to Amy on that count.
Sure. Just really quickly, as I think through this, and it goes back to this point of learning how to learn, we have in these different regulatory and other flexibilities put in place now had an experiment going on in action. And so we need to cross-check when the regulatory and other flexibilities are in place, what happens to participant safety or patient safety? What happens to alignment or misalignment of incentives? What happens to efficiency of use, generation and use of data? And we need to systematically answer those questions so we understand which flexibilities should persist and which ones should be brought back. Last thing I'll say is, as the public health emergency ends, naturally many of the flexibilities put in place will be sunsetted. So it's incumbent upon us to start doing that learning now so we have that information to push us forward.
Thank you, Amy. Let me ask both Mina and David whether there were elements that your colleagues mentioned that you'd like to hear or offer some elaboration or underscoring on as you think about ways in which the commission can make a difference. David, let's start with you.
I think I just come back to this idea. We often talk about those giant numbers, $4.4 trillion last year on medical care. 85% of that's on chronic disease. Much of chronic disease is avoidable if you go upstream and really sort of address it in its early stages. And it's our sense that there's about $1 trillion spent on chronic disease medical care for the diseases that are the byproduct of living in poverty. So I just think sort of framing this sort of as an anti-poverty program as a value creation strategy is I think a valuable one. And I liked the earlier comment about how the highway system was suggested as a response, as a national security investment. I think there's different ways we can just sort of start framing it, that this investment, this improvement of health as a way of not necessarily fixing the medical system, say, but getting us these dramatically better outcomes in terms of a stronger economy, a stronger nation, a fairer and more equitable country. I think that's the kind of framing that you have in this already, and I would just sort of double down on that.
Appreciate you underscoring that, David, because at least half of the output of the commission's work will be analytic in nature in order to provide some qualitative, but especially quantitative sense of opportunities potentially at hand or consequences clearly at hand if we don't marshal the alignment of activities necessary. Mina, items from your perspective that you would like to underscore that you might have heard referenced?
Yeah, absolutely. So I'm going to pick up on something that David had said in his remarks about talking about the shock that the COVID-19 pandemic created. And it ties into some of the things that I saw in the chat where people were saying, oh, we've been talking about all of this for decades, and what's going to be different now and what's going to change. And I think it is that. It is the fact that our country has gone through this shock that's been a shock both in terms of things like how care had to be provided differently, like coming back to the discussion about waivers and flexibilities, that then provides this unique opportunity to have innovated so quickly that we can learn from. Workforce burnout, capacity constraints. There are, structurally speaking, there have been shocks to the system that will enable us, and that it's incumbent upon us to leverage to be able to drive change forward in a way that maybe has not happened before. And the second point is this reframing, as David mentioned as well, where what has happened with the pandemic has enabled many people to see more of healthcare as care and as a population issue. Issues of equity are now household conversations, whereas before social determinants of health, it was something that the policy wonks talked about. Now issues of structural inequities and social needs, these are now part of more everyday conversations that also enable us to reframe how we think about where we invest, what activities we do to be able to drive change forward. And I think a good example of this is behavioral health as well. I know we didn't really touch too much specifically on that, but I see behavioral health as a good example of several of these aspects where we have a behavioral health crisis. There is more conversation now about behavioral health than ever before, and how critical it is to incorporate behavioral health as we are addressing the health of people, where again, it's going to take that multi-sector approach where we have issues of access to care because we don't have a fully mobilized behavioral health workforce, where we can leverage innovations to improve that access and to be able to, again, provide more of these services in new and innovative ways to ultimately, save down the road and improve outcomes. And then it comes back to, again, where all of these social needs intersect and intertwine. So I think behavioral health is a very good example of this, where I know for us in the Medicare program, it is a priority. But again, we can't do that work alone. And so the work of this commission to move this to the next level, bringing everybody together in this way, is going to be very important.
Thank you very much, Mina. We're into the last few seconds, so let's do our lightning round. Amy, would you kick us off with your critical point?
So my critical point is learning how to learn, and especially as we build the data infrastructure.
Thank you, Amy. David?
I think we are going to start talking about a market that values health and not medical care.
Right. Thank you. Mina?
And I would say that we're moving our healthcare system to caring for people as people, rather than a patient that comes into a specific episode of care with a specific diagnostic code and a specific claim for a service being provided.
Wonderful. That's a great last word. And thanks again to each and every one of you. This has been a very rich, if rushed discussion. So thank you all for joining. Please send us, you in the audience, any suggestions you have for the important framing questions for the commission work streams, or any other observations and suggestions you have. Again, thank you for joining today, and thank you in advance for responding to our work together in engaging the imperatives, investment imperatives for a healthy nation. Be well, enjoy the holidays, and we'll be back next year with a firm commitment to making progress with the commission. Take care.